Thank you for joining us today for this webinar. My name is Hilda Mwangi. I'm the CEO of Has Advisors, and I'll be your host today. Before we get started, I just want to share like an overview of what to expect during our time together. So the first thing is we'll go over our main topic. Our main topic is enhancing hospital at home programs with AI for health equity. We'll have a little bit of a discussion, and then we're going to end the webinar with a Q&A session. And with that, I would like to introduce the amazing team that will be running the webinar with me today. First, we have Marion Davis. Marion is a marketing consultant, and she is also a patient advocate with a very strong understanding of care outcomes as well as patient preferences. So we're very lucky to have Marion as part of our team. Next, we have Jeff Waffle. Jeff is our AI guru, and Jeff has been in AI long before we knew what AI was. And he's been building and training AI models and has an extensive background in healthcare. So we are very lucky to have Jeff. And last but certainly not least, we have Dr. Jenny Stanford. She's a physician and also an innovative care model specialist, and she brings a wealth of knowledge on medicine as well as how AI can truly impact patient care. So we're very lucky to have Dr. Stanford as part of our team, and she will be leading us through today's main topic. And with that, I will pass it over to Dr. Stanford.
Thank you so much, Hilda, and thank you for all being here. I will share my screen and pull up the presentation so we can get started. All right, so I want to give you all some background on this topic. Many of you are healthcare professionals yourselves, but I know we come from all walks of life and all occupations, and so I want to make sure that's relevant to everyone. So the context of this is to describe an innovative care model that was a hospital at home program and is still running, but just to kind of give background on why it was established, what the goals were, and how I think we can apply those concepts more broadly. So the objective of the hospital at home program was number one, to reduce healthcare costs. And I think that's important across the country in different care models, but definitely in a hospitalization setting, which we know carries a high cost associated with healthcare. But what this program also did was deliver care in an innovative way, such as in the patient's own home. So we all know that sometimes there's resistance to patients wanting to stay in the hospital, and rightfully so. There's some discomforts associated with that and disruptions to their life, which are oftentimes necessary. But in these cases, we were able to provide good quality, appropriate, effective care in the setting of the patient's own homes. And so you can imagine the benefit that that has for the patient. There were some baseline eligibility criteria, and these will explain a little bit more about why these exist. But this was sponsored by a university health plan. So the patients had to be members of that university health plan in order to qualify. And again, this was a cost savings initiative for that health plan. Now, the next criteria makes good sense, but is interesting when you think about the logistics. So patients had to reside within a defined radius of the base location. And for this program, that was within a large county in a metropolitan area. And the rationale for this is the team that was delivering care in person had to be able to access the patient quickly and efficiently. If number one, if obviously healthcare needs escalated and severity of illness was worse, but also so that we could serve more than one patient at a time. And then the patient had to live in a single family home, an apartment, or a condominium for privacy purposes and accessibility. So within the patient admission process, I think it's important to understand kind of how this flow worked. So the initial assessment occurred in the emergency department in most cases for these patients, and I'll talk about a few caveats to that. But essentially, when patients arrive to the emergency department of hospitals within that county and the metropolitan area, they were designated on the ED tracking board to remind the ED physicians to consider the hospital at home as a potential option. And if any of you have been around an emergency department setting, obviously it's very hectic and a lot can be happening at one time. And so remembering different details, especially new initiatives and things that aren't necessarily integrated in the workflow as when this first got started, we had to have some reminders for the healthcare team to consider this as a disposition option. So if they met these criteria that we'll mention next, they were designated on the ED tracking board next to the banner by their name. So for easy visual recognition. And so basically what they had to do was meet the university health plan criteria, the location criteria, and the home criteria. Now, as we kind of went through the process of their emergency department course, so as the ED providers diagnosed and began to provide treatment, then what we were looking for at that point was a level of care that could be safely provided in the home. You can imagine there are a lot of illnesses and disease states and patient statuses that would not be of low enough acuity to be able to be taken care of at the home. But for those who were of that observation level criteria is kind of what we were looking at. So those who didn't meet inpatient criteria for hospitalization, but were more on that observation criteria, milder illness sort of threshold. And so at the end of the ED course, if their severity of illness met that criteria, and it was deemed that they could potentially be cared for at home, what happened was on the admitting team, just like you would be admitting from the emergency department to the hospitalist, there was an admitting physician on the hospital at home side. And so the emergency department physician reached out directly to the hospital at home admitting physician and had a physician to physician sign out how we would normally do when patients are admitted to the hospital. And we all know that the handoffs in healthcare are a time of very necessary attention to the patient to make sure that errors are not made and specific care is continued in an appropriate way. And so these handoffs were essential to kind of have a physician-to-physician discussion of, is this patient really a fit for this program? And if the admitting physician for hospital at home felt like they indeed were, then it was back to the patient because there were additional things that we needed to know from the patient to ensure that they were a good candidate. So they had to have internet within the home. Obviously, you can imagine that that is important to the remote monitoring and the AI capabilities of the program. They had to be comfortable using a tablet or other technology. So, sometimes patients with chronic illnesses ages vary, and you have some older patients, some younger patients. And so you naturally also tend to have some different comfort levels with technology. So that was important to assess. The other thing, and this was interesting as you kind of work through this, so the patient had to be willing to allow a care team to be in their home at least 1 to 2 times a day. So if you think about patients who are receiving IV antibiotics or maybe IV furosemide for diuresis, different treatments that had to be administered multiple times a day, sometimes those patients had to have multiple visits. And so it's a lot to have a whole team and all this equipment in your home. And so patients kind of had to be willing to do that. And then is this what they wanted? So essentially, you're looking for patients who are willing to participate in the program and were interested. Some patients were more comfortable in the hospital setting in terms of their level of monitoring. And so it was important to kind of tease that out. So the interesting thing is, so the next step, if all those questions were yeses, then they were admitted to the program. A team went out. The team consisted of medics and had a virtual registered nurse who did some medication reconciliation, history taking, and then the admitting hospitalist was also present virtually. And so that was the team that kind of did that intake visit. Um, as far as what this looked like, so there was a lot of technology that was used, which is why it's extremely relevant for what we're discussing today. Current Health is the vendor that was chosen to apply the technology. And so they had devices that the medics physically took to the home, blood pressure cuffs, other oxygenation monitors, scales, the tablet, those types of things. And so as that was kind of all set up, the intake visit proceeded and the patient's treatment was initiated. The other thing that was kind of interesting to mention on this intake visit is depending on where the patient lived and how fast they left the emergency department, we kind of had to manage that lag time because there were sometimes maybe an hour or two, maybe even slightly longer than that before they arrived back home. And so the team kind of had to be ready to deploy and meet that patient to ensure a safe transition. But I would say kind of talking more about what this looked like on a daily basis as the patient was provided care. So they wore monitors, they wore the blood pressure cuff, the oxygenation assessment, the heart rate monitor. And what those did is they seamlessly integrated, well, they were remote monitoring back into the system of Current Health. And so that was averaged every 15 minutes for their vital signs. So blood pressure, heart rate, oxygenation were averaged over 15 minutes. And then every 4 hours, those averages were put into the EMR through a seamless transition. So Cerner was the EMR that we were using at the time. And so when the physician would pull it up, what they would see is an average every 4 hours, just like we would see every 4 hour vital sign numbers, in the hospital setting. So that was, from a physician standpoint, looked very similar to what you would see on an inpatient care model. The scale was used to transmit, as you are probably familiar with remote monitoring of the scale of body weight scales and things like that, that also integrated seamlessly. So the team, the same as the intake team, the on-site medics, the virtual nursing, and the physician met with the patient once a day. If we went out once a day, the physician only was involved in a traditional visit once a day as far as history, physical exam, and then making a treatment plan. And then if the patients had to be visited other times during that day for, treatment multiple times a day, then the nurse was virtually present with the medic team, and the physician was on call, as needed. Things that we were able to do, pretty much what all we needed to do. If there was a service we couldn't provide, then that was a criteria for them to have to be transferred to the hospital. But things like obviously vital sign monitoring, physical exams, Bluetooth stethoscopes. Echo is a company that offers Bluetooth stethoscopes, which can be, obviously heard on the physician end, and a device is applied physically on the patient's chest by the on-site staff. Laboratory testing, so blood tests were run every day. Treatment, so the medics carried the treatments that they knew they needed for that patient, like the antibiotics, the furosemide, the other intravenous treatments. And then if there were anything that we needed to get from the pharmacy, that was done after a morning huddle each day that we had with the team, and the pharmacy would deliver those products for the team to carry with them. And so I would say most people stayed in the program for 48 to 72 hours, probably similar to care that observation level care in the hospital. That's usually 48 hours or less. So maybe another 24 hours or so on these cases, but it all depended on the patient's response to treatment. And they were either discharged once they improved a sufficient amount, or they were transferred back to the hospital if something came up that needed to be addressed on the inpatient side. And so I think we'll talk about this for a minute, and then I would love to kind of get into the chat and see what comments are being shared and different things that people may have, and we can work backwards if we need to. But these are the take-home points of what this hospital at home model offered in terms of our considerations for AI implications. Okay. So real-time monitoring. So this was continuous data transmitted every 15 minutes. What I didn't mention earlier is there were alarms set for parameters for vital signs. And so, for example, if blood pressure exceeded the top threshold of, for example, 180 millimeters of mercury on the top, then an alert would be sent to the monitoring nurse in real time. The nurse was able to get on with the patient on a visit if necessary to check in on them, check in on their symptoms and their clinical status and that kind of thing. And so this continuous data, timely interventions, that's what allowed us to keep these patients cared for in the comfort of their own home and reduce these associated hospital costs. So in terms of resource optimization, we were able to get a lot of analytical data to kind of know where we needed to allocate our resources and how this workflow could be streamlined. And so, for example, these patients, some of them were high utilizers of the healthcare system, others weren't. It just depended. But we definitely did target some of those higher utilizers to help prevent hospital readmissions, which we know are kind of things that we see across the nation. In terms of engaging the patient, so you can imagine there were quite a spectrum of patient engagement. So we want patients to love the service, right? We want them to appreciate the convenience and the comforts that they had. And by and large, they definitely did. They felt like, the team spent longer with them and they felt like they got more hands-on care and their family was with them. There's things that were more comfortable in the setting of which their care was being provided. I would say, though, this interactive technology was part of their engagement too, because you can imagine that they are at the forefront of seeing these vital sign numbers and these alerts and alarms. And so they were able to proactively reach out to the nurse if something was going on that was concerning them. So there was a good two-way communication there. With the data integration into the EMR, so this is, and I think it was Stacy at the very beginning of the visit before I shared my screen. She was talking about reducing administrative burden and the seamless data integration into the EMR. This was not anyone behind the scenes having to input all this information. I mean, it was really from a technology standpoint, really streamlined in terms of the workflow that the whole team was involved in. And so I think that's an important thing that we can talk about and allowed us to really get a picture of that patient's overall stay in the hospital and see those numbers just like we would, if they were cared for in person. And then, of course, cost reduction. Healthcare is so expensive, and that's a crippling thing that we face throughout the nation in terms of our hospital systems and payer sources and things. And so emergency departments are expensive. The treatment costs a lot of money. And so you go from an emergency department to an inpatient floor where care continues to be expensive. And so caring for these patients at home definitely reduced those healthcare costs. And through our patient satisfaction surveys, we're able to see that it definitely improved the patient satisfaction as well. So, before we kind of get into these discussion questions, I'd love to answer some specific questions about the hospital at home. Let me see if I can get to the chat. Back to this as well.
So none of these patients were GIP level of admission. They were all observation level.
So what we had certain blanket diagnoses that were acceptable, right? we had cellulitis, pneumonia with a 2 liter oxygen requirement or less. I think two, may have been four in some patients, kind of a case by case basis. Heart failure of patients who were not requiring oxygen, so didn't meet inpatient criteria. So overall, yes, although again, there was some provider discretion there if they seemed to be a good candidate or they really only had one problem that could easily be addressed.
Thanks. And I'm also just interested to know, in
Mhm.
terms of AI, what tools are you leveraging or do you see being leveraged in the future to sort of impact that administrative burden? So, for example, the clinical team, the nurses, are you using any sort of transcription so that they can really just be in front of the patients and have their notes transcribed and then, get back and just kind of go through and correct them? Um, and other sort of administrative you know data, I guess, that has to be completed before an observation or hospitalization. Are you leveraging AI at this point for any of that? I think Jeff already answered my question about sort of proactively looking at this data and being able to say, okay, this patient is looking like they're headed towards sepsis. I'm a geriatric and palliative care doctor, so in the community-based setting, it would be great to get to a point with AI where we can have these tools that let us know Mrs. Jones is starting to tank.
Mhm.
And it's probably going to happen within, 48 or 72-hour window so the clinicians can get ahead of that. I guess I'm interested in like what AI exists for that or what AI is coming for that.
Yeah. Well, so you make a great point on the transcription, and I'll speak to at this point, we capped at four hospital at home patients per day, just based on the medic staffing that we had. And so at that rate, it was 2 to 3 medics on each team. So 2 to 3 medics in the patient's home at one time. And so they were doing a bulk of the documentation, and then the physicians were adding addendums and editing any documentation that was necessary. And so I feel like we had a good reduction of administrative burden on the physician side, but I can definitely see while physicians could dictate, the medics didn't really have that ability in terms of dragging things like that. But with a higher volume of patients, I can see how that would definitely be something to utilize to save time and administrative burden for sure.
Yeah, and I was actually speaking to, and maybe Jeff, you know this, I was actually speaking to AI tools that can, as the medic is there, as the nurse is there, talking with the patient, that can proactively transcribe that verbal output into a
Mhm.
note so that they can then just go and edit that note. I mean, I think that's where we are hopefully headed, and need to head, with the great, AI resources and tools that we have.
I definitely think with a higher patient volume for certain. This program was in its infancy. I was actually part of getting it off the ground, which was a unique experience. But I would say after 12 months in, we were kind of consistently at that four patient load per day. But definitely as that would continue to increase, that more solutions like that could definitely be employed. Absolutely. I did want to talk. You mentioned the triggering sepsis criteria. So we had something kind of similar to what you would see on the inpatient floor, where specific markers were included to provide an alert to the clinical team, whether that be heart rate, temperature, lactate levels, white blood cell count levels, that kind of thing. We did have that same trigger within the patients monitoring on the hospital at home program. And so we were able to see, and then you had a daytime physician and a nighttime physician. And so there was someone kind of ready to step in at any point. We did have a couple, I personally was involved in transferring a couple of patients based on decompensation. And then, also was able to kind of see some as they improve on those trends as well.
Okay, one more question. I don't want to
Yeah.
I don't want to hog all the questions, but
Mhm.
I was also wondering, you talked about the high utilizers that you had in the program. So were you able to kind of track that utilization going forward to see if with your hospital at home program, if, maybe over a 2-year, 3-year period, those high utilizers maybe stop being high utilizers from a GIP admission standpoint, and if, there was an effect on that utilization from a cost and, quality and satisfaction perspective.
Yes, and that's a great question. I myself personally took care of multiple patients multiple times, and you had those same patients would have within that period of time usually 1 to 2 admissions where they didn't meet hospital at home criteria for something, they needed a testing, like if a patient needed an echocardiogram or a stress test or MRI imaging, things like that that we couldn't do in the home, then obviously that required a regular admission. And so I did see myself, though, several patients being admitted on multiple times on this hospital at home program where they would have had to have been in a GIP admission at that point, and so was able to see those numbers definitely decrease. And oh yes, the satisfaction was so neat because again, some of these patients, particularly, it's very burdensome for them to even get transportation. I mean, EMS is sometimes their only option, and so having that as an option, satisfaction wise, was huge for them.
And did you have a criteria that did there have to be another caregiver in the house or no?
There did, yes. Because a lot of times there was a lot of kind of logistical things with the technology and whatnot, and that caregiver didn't have to be there 24/7, but they definitely had to be available and there for a good portion of the time, specifically during the visit, so that we could make sure that the patient had all the resources that they needed.
Okay, and one more question, and then I'll shut up.
Yeah.
The lecture is titled Enhancing Hospital Home Programs with AI for Health Equity. So, did you have populations that were more disadvantaged, that were poorer, that were in, urban, stressed areas, food desert areas, and how did this program serve those customers and improve health equity and, get them the care that they needed?
That is a fantastic question, and I'm grateful that you brought that up. So these were all urban patients. And so yes, we had an urban population. The medic team was trained and skilled at assessing social determinants of health. And so they were well aware of the community resources and the health plan resources that were available for these patients. And so I don't think once we left the patient's home where they weren't supplied with additional resources, both that would enhance their healthcare and obviously the equity therein, but also potentially reduce costs on the system down the line by providing the resources that they needed.
Sounds like a great program. Thank you.
Yeah, thank you.
Yeah, that's great. Does anybody else have another question? So Stacy wrote, how is AI being leveraged in Corner to decrease burden for clinical team documentation? I think we already answered all
Yeah,
that.
so we talked about that. Yep.
Yeah. What was the ROI for cost and indirect, like satisfaction and other quality measures?
I don't have any great data, like number wise, but I can definitely tell you just from experience of the program, the positive outcomes that we saw. I definitely think that there are plenty of those numbers that are available, but I don't have any off the top of my head.
Yeah, I hope you'll publish this because, for me, as a former CMO, working with a health plan, it was very hard. I tried to get a hospital at home program started with the health plan, and they just didn't see the value, and they were quite frankly behind the curve, and what I would call laggards as compared to early adopters. But it would be great if you could publish your data, and I think that forward-thinking health plans really need to get on board with models like this now, particularly with the impact that we're going to see from AI, augmented intelligence.
Certainly, certainly. I'll definitely look at that and see what options we have for that for sure.
Yeah, and one thing that I'd also like to add in terms of tools and AI is, if you think, and maybe Jeff can add on to this, if you think about what machine learning is, machine learning is the ability to predict what happens next. And so, even when you're thinking of things like sepsis, it's you're training these models to, look at those key factors, taking, crawling through physician documentation, looking at the patient's lab work, and then predicting what's going to happen, whether it's in the next 24 hours or the next 3 months or the next what have you. And so I think this is why it's so exciting for AI is that as human beings don't do a very good job at predicting, but now we have this tool that gives us the ability to feed this information, train it, look for this, crawl into all of this documentation and give us some sort of analysis on what are
Mhm,
we going to anticipate next, right? And
mhm,
so I
mhm.
think I think we're going to get to see a lot of good care. I don't know, Jeff, if you want to add on to that a little bit in terms of natural language processing and what that's going to impact.
Yeah, so I think that like when you look at healthcare and AI, AI is like a very natural fit for healthcare, or like there's a lot of healthcare aspects that AI can help with, right? Where because there's a lot of data, for instance, right? Like there's a lot of patient data, and then there's a lot of communication with like doctors communicating to patients, or even just like transcribing data, like all the paperwork the doctors have to do, or all the medical records, right? And so when it comes to AI and healthcare, it's really not a question as much as like what AI can do for healthcare, as much as like how much healthcare will allow AI to do for it. I think if we were in a world where the decision makers didn't have to worry about, say, like HIPAA or the privacy of medical records or being sued for AI mistakes, right? If we were in a world that was like that, the AI transformation in healthcare would be incredible, right? Like you'd be able to
Mhm,
do all these
mhm,
different things. You'd be able to reduce, like you're asking, like the burden on the clinical teams. Documentation would take 1% or 10% of the time that it used to take, right? Where the predictive ability to be able to predict diseases or outcomes would be greatly enhanced. But the issue is that like data is very um, risky and personal, and there's a lot of
mhm,
laws and regulations around it. And AI, again, is very, very data driven. And so the solutions are there basically for all of this stuff. To have 24/7 AI medical nurses that could help with things, or again, like documentation can go incredibly fast. We could do all kinds of things with predictive analysis for all kinds of sicknesses, right? Besides sepsis, it's just this data issue with the risk that's involved with it.
Yeah, yeah. And so, and even in addition to all of that, the risks, there's also the biases, right? That we also have to consider is, when you're training these models, based on the data, it's really understanding what that data is and where it's coming from. Because if obviously the data is biased, the outcomes that it provides will be very biased as well. So I think that's also one of the other things that has become a big discussion point is that as AI is more implemented, and especially within the healthcare setting, it's just being very careful in terms of data bias as well as data privacy and data security. All those things kind of go
mhm.
together in making sure that as an organization you're protected from the consequences of that going wrong. Right.
Mhm.
Right. And
And
that would, oh,
Mhm.
I was
Go
going to
ahead.
say, I was going to add to that that like even sort of like a chain of command responsibility, right? Where sort of understanding the hand-in-hand nature of the human and the AI, uh, because if you are going to have AI making predictions, right? At what point in time is the AI responsible, or the doctor responsible, or the hospital responsible? And so even
Mhm.
figuring out that type of paradigm where this comes up in other industries, where like how much is the person supposed to do the work? How much is the AI supposed to do the work? What happens when there's conflict there? It's just in healthcare, it's people's lives that are at stake. And so
People's
it's
lives. Yeah.
much more important.
Yeah, but I think that, and there are certainly places that are starting to innovate around this. There was a study that I read about recently. I think it was in a Canadian journal about a hospital that was using AI to generate sepsis alerts and reduce death mortality outcomes. There was another group using AI to predict, who would be the best patients to be engaged for palliative care. So I think that people are certainly doing things with AI, and there are things that can be done in clinical settings, but I think that there's this educational component that needs to also come to the table with clinicians because you're going to have certain clinicians, probably like all of us on this phone, who see AI as sort of like an assistant, which is what it should be. It's like my assistant when I'm using Perplexity and all the things that I use. It's an assistant. I'm not going to it for a diagnosis. But, I think there are a lot of people that will use it. I mean, I recently posted about AI, doing calculations for drug conversions for patients in palliative care with complex opioids. But I also made the point that it has to be checked by a human being because people's lives are at stake. You can't go from morphine to methadone based on an AI algorithm. There has to be a human touch point. So I think that, along with the ethics and the equity piece, because that is big, because garbage in is garbage out from a health equity, unless you have biased data going in. So I think that like it has to be multifaceted: education, bias, and doctors understanding, and nurse practitioners and PAs understanding that it's not a substitution for us; it's an assistant.
Certainly. Well said.
Yeah, that's a very good point because yes, I can see AI AI is so powerful, and obviously it can think and predict beyond human, and it's easy to give it so much power and just let it make decisions. But I completely agree with you. It's absolutely right to see it as an assistant, not as a decision maker.
I just want to say I was on a health tech platform recently. This was for mobile dentistry, and you could choose between speaking with a dentist to get a diagnosis or having an AI diagnosis. And I really dislike that because I would rather have the human interaction. And where I needed help, specifically in my case, was streamlining the gaps between. Like, I enjoy the visit with a human, but so I'm homebound and I work with a lot of spinal leak patients, and I work with a lot of doctors working with spinal leak patients. And it's the gaps between, like how to easily set up equipment to come out to the house to test for different things, how to keep track of all the different aspects going on, but not to replace the human aspect. And I think that's a really poor use of AI there, was as a substitute for the clinician themselves when it could have been used, because the clinician I talked to could not figure out how to find the resources. And that could have easily been streamlined, the gaps between visits and patient-physician interactions or clinician interactions.
I think you're absolutely right. And like this is sort of going back to what Stacy said, is that there's a lot of times when people are building these AI systems where they're not thinking about this, right? And I think that really that the idea that everyone needs to go into is that this should be an assistant, right? Like you should really build the AI as an assistant at all times, like currently. And so whereas they had this where it's like, no, it wasn't an assistant, it was an option, right? And it's just like, that's just a bad setup and it's not going to provide what you're looking for. Whereas they could have used that AI power and provided an assistant to the dentist or whoever.
Send out dental x-rays, yeah, and then have that.
Been able to handle that workload, but not show it to you in that type of way. And again, like this is what people need to figure out. And we've brought up all of these different issues, and these are real issues, right? Like these are actually realistic issues that people need to figure out when they're implementing the system. But there are things you can figure out, right? Like again, like make it an assistant, protect the data that you're using to train it on, properly handle it, like do all these different things. But then, as Stacey was bringing up, like education is an important part because like, these are realistic issues that yes, people can overcome. There's also just a bunch of made up issues that a lot of people have right now. There's a lot of misconceptions where there are doctors or administrators or whoever who aren't really aware of what AI is. They only know about it from say like a sci-fi perspective or the jokes that they hear on late night TV. Maybe they've seen a couple of memes about ChatGPT, and so they view AI like that. I was like, no, like this is really just a very, very powerful tool that if you could figure out how to handle some of these risks and some of these liabilities, would just transform your industry and reduce costs by an incredible amount and increase healthcare outcomes.
Yeah, so I have an interesting thought to throw out here is one of the biggest issues with healthcare is accessibility, right? There are people who, and especially this whole topic we're talking about is there are people who might be in remote areas where access to a physician becomes very difficult. So, because we're talking about it from a physician perspective, but what about from a patient perspective and having these tools to be able to go into a tool and write down how they're feeling, what their symptoms are, AI spitting back out, this is exactly what you need to do. And now you have an issue of self-treatment. So I guess where the boundaries or where, do we put some sort of protection against this AI to make sure that it's truly being used, with supervision?
I will say from what I've
Mary,
seen,
yeah, you have a
yeah,
great
from what I've
perspective on that.
so I use ChatGPT a lot and I use it very successfully. With a spinal leak, you tend to have a lot of secondary problems. Like you have, and there are a lot of people who choose to go on palliative care instead of trying to get another blood patch because unfortunately there are some issues with accidental punctures during blood patches making things worse. But I work with a large group of patients and they do use ChatGPT a lot. But there was a study done that showed that patients, when they were interacting with AI, there was this one study that showed that patients interacting with AI got more empathetic answers. And I mean, I don't really know how they judge that, but empathetic and correct
Wow.
based on interacting with AI versus physicians. But there has also been a study, because I know a lot of therapists say, well, what if it's AI that's actually talking to people, that could replace us? But there was another study that showed that people prefer knowing something is coming from a human, even if they like the response objectively better from AI. And what I have seen a lot of patients do is, yeah, they go to ChatGPT. And first of all, ChatGPT will keep reminding you over and over to talk to your healthcare provider until like an annoying point where you have to say,
Yeah.
stop. I get it. But so a lot of people I've seen, and this is especially women who are pushing for spinal leak care, they will use that as self-empowerment to help them better advocate, but they will constantly go back to physician and keep pushing and pushing. And I don't really see it as an issue, especially for women, of them just taking that and leaving it at that. They want it to come from a physician, but they're not getting the answers. They're not getting correct answers as far as spinal leaks from a lot of physicians. So they keep advocating and they use ChatGPT to help them better find research sources that they can go get and then bring with them to the doctor's office. So I don't really see that as a huge issue. And to Jeff's point, I have had some doctors say like, "Oh, watch out, don't use ChatGPT." But I don't think they're understanding how patients are using it because patients want the comfort of a doctor saying like, "Yes, this is the issue. We're going to focus on this. We're going to, monitor this." That's what I see a lot is there's an emotional aspect there where patients don't really feel comfortable with it just coming from ChatGPT or just what they read online. They would like it to come from a physician, but many times they're not getting the answers they need, or they feel like they're not their problems are not being taken seriously, so they are using stuff to help them self-advocate, but they are continuing to keep speaking to a physician or look for a second opinion and keep on pushing for better healthcare.
Marian, I'm going to suggest to check out Perplexity AI. It's a wonderful tool and it's like Chat GPT plus Google. So it's actually not just giving you a citation, but it's giving you information and sort of answers to a question. So whereas you go to a bunch of websites to look at, if you go to Perplexity, it'll actually give you a summary. So I use chat too, but I use Perplexity more because, like I say, it's chat plus Google. And that's a good resource. And, to your point, Hilda, I think there's a ways to go. There's a huge frontier in the rural population. A lot of innovation started with COVID. We had gram pads for people, that were elderly and, from a palliative care perspective. So I think all bets are off. And I think that those innovations need to be, again, tied to a clinician because it's an assistant. And so maybe the technology is gathering all of that data from those models and producing differentials and possibilities. And then that's going to a clinician who can actually, based on our experience and training, interrogate that information, with conversation with an individual.
Yeah, absolutely. At least that's the right way to do it, right? And this and even patient advocacy, because if like your clinician is not giving you the information that you need, but these tools are saying, consider X, Y, and Z, right? There's a part of patient advocacy that we don't see today that probably we'll start seeing more and more of as patients become more aware and knowledgeable about the conditions that they have, exactly to Marion's point.
Well, I think
I'm sorry, go ahead.
I was going to say, so I'm working on a project where we're creating an AI interviewer, essentially, where it could interview people about specific questions. A lot of these are actually healthcare questions, and then taking that data and then predict, subdivide the people into different cohorts and then make predictions based on it. And so I'm looking at that, where it's all right, this is an AI sort of interview process, right? So if you take that and you kind of take the functionality of ChatGPT and sort of, then the clinician, you could have a system where a person is having, a healthcare conversation with an AI healthcare advisor, right? But then that information is being stored. And then when they go to the clinician, right, they get to that clinician step, then all that interview steps have already happened, right? They've already gathered all that initial interview information that you either get from the nurse or from the doctor when you get okay, what's wrong with you, right? You can sort of cut through all of that. And then even with some of the other solutions we're talking about, like OCR, where or even just transcribing, where a doctor would, I'm not personally a doctor, but I've heard they do a lot of paperwork, right? And so you could just slash that paperwork down to 10% of what it actually is. And so that makes the doctor more available, right? So if you take, I don't know if there's going to be the silver bullet solution, right? But all of these little pieces that are just all these different assistants to a doctor. One of the ways I was describing it to somebody the other day is take that same person, but then just give them 12 hands, right? And now they'll be able to work like that. And in that way, these doctors will be more available, since we will just be streamlining some of the work that they're doing that can be automated with AI, if we get it all figured out.
Yeah, that would be amazing.
Yeah.
A lot of innovation coming down the line. I'm sure next year at this time we'll probably be in a very different place with AI. Just so much innovation is happening. And with that, we are at time. And I just want to thank everybody again for taking time to join. And, look out for more webinars to come. And yes, we'll connect. So thank you so much.